Have you ever wondered what are the causes of skin cancer? The main external cause of skin cancer is ultraviolet light from the sun or tanning beds. UV rays damage DNA and skin cells, and over time these mutations build up. Other risks include chemical exposure like arsenic, chronic skin trauma such as scars or burns, and HPV infections which can lead to squamous cell carcinoma. On a molecular level, mutation in key genes drive different cancers. P53 in squamous cell carcinoma, PGCH1 in basal cell carcinoma, and BRAF in melanoma. Normally, DNA repair systems fix this damage, but when they fail, as in xeroderma pigmentosum, mutations accumulate rapidly. People with fair skin, older age, or a weakened immune system are more at risk. Altogether, these environmental, genetic, and host factors make skin cancer the most common cancer worldwide. This is normal, healthy skin. The epidermis sits on top of the dermis, and the basal layer constantly makes new cells. Normally, the DNA in these cells is protected and repaired correctly. But when the skin is exposed to UV light or chemicals, the DNA can be damaged, for example, forming thymine dimers. If this damage isn't repaired, mutations build up in genes like P53 or BRAF, which normally control cell growth. These mutated cells begin dividing uncontrollably, a process called clonal expansion, forming a small cluster of abnormal cells within the epidermis. Over time, the tumor grows deeper and crosses into the dermis, becoming an invasive carcinoma. Once cancer cells enter blood or lymph vessels, they can spread to other organs, a process called metastasis, which makes skin cancer dangerous. To summarize, the disease progresses through three main stages: dysplasia, where the cells look abnormal but stay in place; carcinoma in situ, when the cancer is confined to the epidermis; and invasive carcinoma, when malignant cells break through and spread into deeper layers. This same process explains the three main types of skin cancer: basal cell carcinoma, which grows slowly and rarely spreads; squamous cell carcinoma, which can spread if untreated; and melanoma, the most aggressive type, because it spreads early to other organs. Now, diagnosis begins with a clinical skin examination using the ABCGE rule to identify suspicious lesions. A stands for asymmetry. A normal mole is usually round or even. If one half doesn't match the other, that's a warning sign. B stands for border. Benign moles have smooth, regular edges. Suspicious lesions often have jagged, blurred, or irregular borders. C stands for color. Normal moles are usually one shade. Skin cancers often show uneven colors, different shades of brown or black. In more extreme cases, you may even see red or blue areas, which are particularly concerning. G stands for diameter. Most normal moles are small. Lesions larger than about 6 mm, roughly the size of a pencil eraser, deserve attention. E stands for evolving. Perhaps the most important sign. Any mole that changes in size, shape, color, or starts developing new features like bleeding or crusting should be checked. In addition to these visible signs, patients may also notice symptoms such as itching, bleeding or ulceration, a sore that doesn't heal, or pain and tenderness. Now let's move on to the diagnosis of skin cancer. It generally involves three main steps. Diagnosis begins with a clinical examination using the ABCGE rule to identify suspicious lesions. A dermatoscope provides a magnified view and helps detect subtle changes. If a lesion looks suspicious, a biopsy is performed and the tissue is examined under the microscope. Histopathology confirms the cancer type and depth, and it's considered the gold standard for diagnosis. In more advanced cases, imaging such as CT, MRI, or PET scans is used to check whether the cancer has spread to lymph nodes or other organs. Overall, the diagnostic pathway moves from clinical examination to biopsy for confirmation and imaging for staging, ensuring accurate diagnosis and guiding treatment. Most skin cancers are treated with surgical excision, removing the lesion with a small margin of healthy skin. In delicate areas, Mohs surgery may be used, removing thin layers until all cancer cells are gone. For small or surface lesions, local treatments like topical creams, photodynamic therapy, or cryotherapy can also be effective. When the disease has spread, systemic therapy is needed. Immunotherapy drugs such as pembrolizumab or nivolumab boost the body's immune response against melanoma cells, while targeted therapy pills block specific mutations like BRAF, BAK, or NRAS, helping slow tumor growth. Radiation therapy can also be used to treat inoperable or residual areas. In short, early-stage cancers are usually curable with surgical or local treatments, while advanced disease requires more complex systemic approaches.